Welcome to the Deep Dive. We're here to give you that essential knowledge boost fast. And today, we're really zooming in on something vital for your MSRA revision, spinal stenosis. We've gone through the notes, pulled out the absolute must-know stuff, and we'll try to make it stick.
Exactly. Think of this as your focused guide, everything you need on spinal stenosis for the exam. So, let's start at the beginning. What actually is spinal stenosis?
Okay, right. So fundamentally, it's a narrowing of the spaces inside your spine. That could be the main channel, the spinal canal, or those little openings where the nerves pop out, the neural foramina.
And that narrowing causes problems.
It does. It puts pressure basically on the spinal cord or those nerve roots, squeezes them. Now, it mostly happens in two places. The neck, that's the cervical spine, and the lower back, the lumbar spine. It's actually pretty uncommon in the middle back, the thoracic area.
Yeah.
And if it does happen there, it's often sort of linked to lumbar problems anyway. Key point. Narrowing leads to nerve squeezing.
Got it. And presumably where it happens makes a big difference to the symptoms you see.
Absolutely crucial difference. So if the narrowing's up in the neck, the cervical spine, well, you might get neck pain, maybe some stiffness, reduced movement.
Okay, that makes sense.
But, and this is really key, it doesn't stop there. It can cause unsteadiness when walking. We call that gait instability. Plus things like numbness, tingling, maybe weakness in the arms and legs, even reflex changes.
So neck issues can affect the lower limbs too. That's important.
Definitely. So for cervical, think neck pain plus those wider neurological signs, upper and lower limb.
Okay. And what about the lumbar spine, the lower back? What's the picture there?
It tends to be a bit different down there. Symptoms usually creep up more gradually. The real giveaway is often leg pain, sometimes with back pain, sometimes not. And it gets worse when you walk.
Right.
And feels better when you sit down or maybe lean forward, like over a shopping trolley.
The classic shopping trolley sign.
Exactly. And patients might describe that leg pain as sort of achy or even a crawling sensation. That's the neurogenic intermittent claudication we talk about. It directly explains why bending forward or sitting gives relief. It opens up that space a bit.
And here's the tricky part, isn't it? The physical examination
Can be totally normal. That's what makes lumbar stenosis sometimes, well, challenging. Your standard neuro exam, motor, sensory, might show nothing much at all.
which really bumps up the importance of imaging then.
Precisely. Things like MRI scans become absolutely vital to actually see the narrowing and confirm the diagnosis.
Okay, so we know what it is, where it happens, and the key symptoms. What's actually causing this narrowing? The etiology.
Well, the number one cause by far is just the wear and tear of aging. Degenerative changes. Think bone spurs, osteophytes growing, ligaments in the spine getting thicker and less flexible, maybe discs bulging or herniating into that canal space.
So mostly age-related changes.
Mostly, yeah. But not always. There are other potential causes to keep in mind.
Like what?
Well, some people are just born with a spinal canal that's naturally narrower than average. That's a congenital thing.
Okay.
Then you've got to think about spinal tumors, though they're less common. Trauma or injury to the spine could cause it.
Yeah.
And certain inflammatory conditions.
Right, so degeneration is commonest, but keep those others in the back of your mind. Now, who's more likely to get this? What are the main risk factors?
Well, age is the big one, as we said.
Yeah.
The older you get, the more likely those degenerative changes are. Also, if you've had previous spine issues, maybe osteoarthritis elsewhere, or those herniated discs we mentioned, your risk goes up.
Makes sense. What else?
Congenital factors, like being born with that narrow canal, having had spine surgery before can sometimes contribute.
And what about lifestyle or job factors?
Yeah, things that put repetitive strain or stress on the spine, certain occupations maybe. Obesity is definitely a common contributing factor too.
Okay, those are the common ones. And you mentioned some less common causes or risk factors earlier.
That's right. And there's a little memory aid that might help you recall some of them. Think ACH.
ACO, like a sneeze.
Exactly. So A is for acromegaly, C is for Cushing syndrome, H for hyperparathyroidism. The second O is for other conditions, things like Paget's disease of bone or ankylosing spondylitis.
Okay.
And the final O, well, you can use it for obesity again because it's common and can be considered here, or just remember it links to the other category. And don't forget, just being born with that congenitally narrow canal we mentioned earlier.
Acromegaly, Cushing's, hyperparathyroidism, other obesity. That's quite handy, actually.
Hopefully useful for revision.
Okay.
So we've covered what, where, who, and why. Let's get into the how. What's actually happening biologically, the pathophysiology.
So we've established the narrowing either the central canal or those neural foramina where the nerves exit. The direct result is compression, physical squeezing of the spinal cord or the nerve roots.
And does it matter what gets squeezed? Cord versus root?
It does. If the central canal narrows significantly and compresses the spinal cord itself, myelopathy, you might see more widespread symptoms, often affecting both sides, potentially bowel bladder issues in severe cases. If the narrowing is more out to the sides, in the foramina, compressing individual nerve roots, radiculopathy, the symptoms are often more localized. Pain, numbness, weakness in the specific area that nerve supplies, like down one leg.
Got it. So the location of compression dictates the pattern.
Precisely. And that compression is what causes the symptoms we've discussed. The pain, the pins and needles, the weakness, all those sensory or motor problems.
And I guess how bad the symptoms are depends on how much compression there is.
Absolutely. The severity directly relates to the degree of narrowing and compression and exactly where it is.
Okay. So a patient comes in, they've got back pain, leg pain, worse on walking, better leaning forward. We're thinking spinal stenosis, but what else should be on our list? The differential diagnoses.
Good question. Always important. So obviously, a straightforward herniated disc needs consideration, can cause similar leg pain, radiculopathy. Then there's spondylolisthesis. That's where one vertebra slips forward on the one below it. That can narrow the canal or foramina too.
Right. Slippage.
Spinal tumors, we mentioned them as a cause, but they're also a differential. Inflammatory conditions like ankylosing spondylitis could cause back pain and stiffness. And you need to think outside the spine, too. Could it be peripheral neuropathy, affecting nerves further down?
What about distinguishing it from vascular issues? That leg pain on walking sounds a bit like claudication.
Exactly. Peripheral arterial disease is a key differential. Both cause leg pain with walking, but typically with vascular claudication, the pain eases pretty quickly just by stopping walking. Rest is enough. With neurogenic claudication from stenosis, the patient often needs to change posture. Sit down, lean forward to get relief. Stopping alone might not cut it.
That's a really crucial distinction to make clinically.
It really is. Other things to briefly consider, maybe a large central disc herniation causing significant compression, any recent trauma or fracture in the lumbar spine, infection like an epidural abscess, and importantly, cauda equina syndrome. That's a neurological emergency presenting with severe back pain, bilateral leg weakness, saddle anesthesia, bowel bladder dysfunction. Needs urgent assessment.
Okay, so broad list. Let's think about that example. Patient with leg pain, worse walking, better sitting. Key differentials beyond stenosis.
Definitely peripheral arterial disease. Also consider herniated disc, spondylolisthesis. Less likely, but keep in mind tumor or infection if there are red flags.
That really drives home the need for careful history and examination. What about how common this condition is? Epidemiology.
Well, as we've touched on, it's strongly linked to age, much more common in older individuals. For lumbar stenosis with symptoms, the note suggests it's around 10% prevalence, which is, quite significant.
10%, okay. But I remember you mentioning something about asymptomatic cases.
Yes, that's the fascinating part. The actual anatomical narrowing seen on scans is way more common than symptomatic disease. That Framingham study mentioned in the notes was quite eye-opening. Found that in people over 60, something like 19%, up to nearly half, 47%, had anatomical stenosis on imaging, even if they felt fine.
Wow, so a lot of people have the narrowing, but no symptoms.
Exactly, which tells you it's not just about the narrowing itself, but other factors too.
And we expect to see more of it.
Probably. The population is aging, and our imaging is getting better and better at detecting these changes, so diagnoses are likely to increase.
Right, makes sense. Let's bring it back to the clinic. Sum up the key clinical features we'd look for.
Okay, general features first. Back or neck pain, depending on the location. Pain, numbness, tingling, radiating down arms or legs, radicular symptoms. Muscle weakness is common. Difficulty with walking or balance. And in severe cases, those bowel or bladder changes, though thankfully less frequent.
And the pattern? Worse with activity.
Yeah, typically symptoms worsen with activity, like walking or standing for long periods, and improve with rest or changing position, like flexion or sitting.
Okay, and drilling down into lumbar stenosis specifically.
For lumbar, think pain in the buttocks and or lower limbs. Might have back pain too, might not. That key feature. Aggravated by standing, walking, especially extending the spine backwards, and relieved by flexion, bending forward, sitting, lying flat.
The neurogenic claudication again.
Exactly. Gradual onset leg pain, maybe weakness after walking a bit. About half might have pain on both sides of the lower back. And remember, pain often worse bending back, better sitting or lying flat.
And the potentially normal exam.
Crucial point again. Motor and sensory exams can be normal, so don't be falsely reassured just by that. That's why doing a careful lower limb vascular exam is so important. Pulses skin changes to help rule out that vascular claudication mimic.
Okay, really thorough. So we suspect it based on history and exam. What investigations do we order?
Imaging is king here. MRI is generally the gold standard.
Why MRI?
It's non-invasive, no radiation, and gives brilliant detail of the soft tissues, the discs, ligaments, nerves, spinal cord, as well as the bone. Lets you see the narrowing and compression really clearly.
Okay. What if someone can't have an MRI, like they have a pacemaker?
Then CT scans are a very good alternative. They show the bony structures really well, can show the canal dimensions. Sometimes a CT myogram is used that involves injecting contrast dye into the spinal sac before the CT, which highlights the nerves and cord really well. It's more invasive, though, so usually reserved if MRI isn't an option.
And what about plain old x-rays? Do they have a role?
They can be useful, yeah. Good for looking at overall spinal alignment, checking for instability like that spondylolisthesis or maybe fractures or bone deformities. They might pick up some degenerative changes like arthritis, but they won't show the nerves or discs directly, so they can't really confirm stenosis on their own. They might show congenital things like spina bifida, cauda too.
Any other tests sometimes used?
Nerve conduction studies and EMG might be used sometimes. They assess nerve function directly, can help differentiate stenosis from peripheral neuropathy, or assess the severity of nerve damage.
Okay, so imaging, mainly MRI or CT, is key for diagnosis. Once we have the diagnosis, what's the plan? How do we manage spinal stenosis?
The main aims are, relieve the symptoms, help the person function better day to day, and ideally prevent things getting worse or causing complications.
And you start conservatively, I assume.
Almost always, yes, unless there are red flags like cauda equina. So non-surgical first. This involves things like pain management medications, maybe injections in some cases. Physiotherapy is really important.
What does physio focus on?
Strengthening the core muscles that support the spine, improving flexibility, teaching posture modification, maybe specific exercises that encourage flexion, which can relieve symptoms. Using assistive devices like a cane or walker can help with mobility and balance. And lifestyle changes, weight management if obesity is a factor, activity modification.
Okay, so try all that first. When does surgery come into the picture?
Surgery is generally considered if those conservative measures haven't worked well enough and the symptoms are significantly impacting the patient's quality of life. It's important to say, though, the evidence comparing surgery versus non-surgical treatment long-term isn't absolutely clear-cut.
Right. And what does the surgery typically involve?
The main goal is usually decompression, basically, physically removing whatever is causing the narrowing and taking pressure off the nerves or cord. This might involve removing some bone, thickened ligament, or disc material.
Just decompression. Or do they need fusion too?
Often, decompression alone is sufficient. There's actually evidence suggesting that adding a spinal fusion where they stabilize vertebrae together doesn't necessarily improve outcomes for straightforward degenerative stenosis compared to decompression alone, and it's a bigger operation.
Okay.
There are also things called interspinous process spacers, little devices inserted between vertebrae. Some studies suggest they might have higher reoperation rates compared to a standard decompression, so their role is debated. And after surgery, active rehabilitation is vital post-op. Physio, again, to regain strength and function. That's key for both short-term relief and long-term outcomes. Some procedures called interspinous distraction might offer some people relief in the short or medium term, but they can sometimes fail later on. So overall, management really needs tailoring to the individual. How bad are their symptoms? What have they tried? What are their goals?
Okay. And looking ahead, what's the outlook? The prognosis and potential complications.
Prognosis is variable. Depends on severity, how much degeneration there is, how well treatment works for that person. But the good news is, with appropriate management, many people get good symptom relief and improved function. Conservative treatment often does pretty well. The notes mentioned about half have no major activity restrictions long term.
And surgery.
Surgery tends to give more rapid symptom reduction initially, but even 5 years down the line, some mild or moderate issues might persist. Interestingly, when you look really long-term, studies haven't shown a massive difference in outcomes between surgical and non-surgical groups overall.
That's quite surprising.
It is. It highlights that conservative management can be very effective for many. Complications to be aware of. Well, chronic pain is a big one, can really affect life. Progressive neurological deficits, worsening weakness or numbness if the compression continues, loss of mobility, obviously, and then the risks associated with surgery itself if they go that route, infection, nerve injury, needing further surgery later.
So it underscores the importance of getting diagnosed and managed relatively early.
Absolutely. Early diagnosis and appropriate treatment can hopefully minimize the risk of those longer-term complications.
Okay, great. So let's try and pull that all together for revision. Key takeaways on spinal stenosis.
Right. It's a narrowing, usually cervical or lumbar spine, most often due to degenerative wear and tear.
Symptoms depend on location, neck pain, plus maybe arm-leg neuroscience for cervical. Leg pain, worse walking, better sitting flexion for lumbar, that neurogenic claudication.
Remember the ACE-shown mnemonic for some less common risk factors? Acromegaly, Cushing's, hyperparathyroidism, other obesity.
Diagnosis relies heavily on imaging MRI. It's preferred. Physical exam in lumbar stenosis can be normal. Don't forget the vascular exam.
Management starts conservative physio, pain relief, lifestyle. Surgery, usually decompression if needed, but long-term outcomes compared to conservative aren't drastically different for many.
Complications include chronic pain, neurodeficits. Early management helps. Key concept: narrowing leads to compression, causing variable symptoms.
And maybe a final thought to mull over as you revise. Really think about how all these pieces fit together, how the underlying cause, the location, the specific symptoms, and the treatment options all interact to shape the patient's journey and outcome.
Excellent. And for more resources to really nail your MSRA revision, definitely check out passthemsra.com.
And freemsra.com as well. Lots of great stuff there.
Absolutely. Thanks for joining us for this deep dive into spinal stenosis.